Well, I'd like to welcome back Dr. Duna Roof from NVISION, and today she is talking about glaucoma. Good to see you.
Good to see you too. Thanks for having me.
Yeah.
Always a pleasure being here.
Yeah, welcome back.
Thank you.
So let's first talk about basically, the problems with glaucoma, the cost of it, the human cost of it. And it seems like many, many years ago, a couple decades ago, someone got glaucoma. It was much more devastating than it is nowadays because
Correct.
there's so much advanced technology and procedures, right?
Yeah. So the reason I wanted to talk about glaucoma today, a lot of people confuse glaucoma and cataract. So I wanted to start by just explaining the difference between the two.
Yeah.
A lot of times I'll have a patient that I diagnose with glaucoma and I tell them, does anybody in your family have it? And they say, oh yeah, both my grandparents had it, they had surgery for it and they were fine. They're probably referring to cataracts.
Okay.
So cataracts are a normal thing that happens with aging, where the lens that's inside our eye becomes cloudy over time. Everybody gets cataracts at some point. However, glaucoma is an actual disease, like getting diabetes or hypertension. Not everybody gets it. And it's a pathologic condition that needs treatment because it can cause permanent vision loss. It's the second leading cause of blindness in the world, and millions and millions of people, we anticipate 78 million people in the year 2020 have glaucoma. I like those pictures at the bottom there on the screen that show what glaucoma vision loss looks like. So in normal vision, we have full field of peripheral vision. As glaucoma develops, folks start losing their peripheral vision. And people who have really advanced glaucoma, what they are left with is a very tiny island of vision that's left, and everything around it is completely blacked out. When somebody develops absolute glaucoma and they completely lose the vision, then it turns completely black.
Okay.
The difficult thing about glaucoma is that it requires multiple follow-ups and requires multiple pressure checks of the eye. Because basically what happens in glaucoma is that the pressure of the eye goes up. When that pressure of the eye goes up, the optic nerve, which is the nerve in the back of the eye that connects the eyeball to the brain, it loses some nerve cells and it becomes thinner over time. And thinning of the optic nerve leads to this peripheral vision loss.
Okay.
So the treatment for glaucoma is basically keeping the pressure down. So the front part of the eye has a structure called the angle of the eye, and it controls circulation of fluid in the eye. And typically, there is a problem in the circulation of fluid in the eye that leads the pressure to go up. So the first line of treatment for glaucoma is to put the patient on eye drops. And those eye drops lower the eye pressure. We have many eye drops that are available, and even in the last 2 to 3 years, we've gotten more and more classes of eye drops that can help keep the pressure down. So typically, we'll start a patient on an eye drop to take once a day, see them back a few weeks later, make sure the pressure is coming down, and basically escalate the treatment according to how their pressure responds. People with advanced glaucoma can be on 3, 4, 5 eye drops sometimes. And that's part of the reason why it's such a difficult condition to have, because people have a lot of problems with these eye drops, as you can imagine.
Yeah, everyone has problems with eye drops.
So the adherence or compliance with the eye drop is a big issue. You have a schedule, you have to take drops in the morning, in the middle of the day, in the evening, before bedtime, and it's confusing, and there's so many of them, and sometimes it's hard to get the drops in, and it's hard to stick to that schedule. In addition...
the thing is, there has been tremendous advances for eye care. But the one thing that seems to be overlooked is how to put in eye drops, even your normal over-the-counter ones, more efficiently and effectively.
I know.
They've kind of bypassed that, but hopefully one day
they're working on it, trust me.
Okay.
Even, I remember when I was doing my residency training many years ago, the chair of the ophthalmology department actually hired 4 engineers to come and do a 1-year fellowship at our department.
Really?
To invent a way to better put in eye drops.
Yeah.
And we still don't have anything. So it's a really tough thing to manage.
Yeah.
But with that being said, not only are they difficult to put in, they're costly. Sometimes even when somebody has insurance and they go pick it up from the pharmacy, the copay can be pretty high.
Wow.
Especially for the newer medications, those are still not yet covered. And they have side effects. A lot of people can get redness, irritation, dry eye, and burning from these eye drops.
Okay.
And sometimes they can be very severe.
Are they steroids or not?
No, no,
Okay.
they're not. So there are many different classes, like prostaglandin analog, carbonic anhydrase inhibitors, and so on. Just many different classes that we can try, but none of them are steroids.
Okay, the reason I asked that, just for my own education, is you often might use a similar type, Flonase or whatever, to relieve pressure in your nasal cavities. Which has not the kind of steroids that bodybuilders use, but have steroids in it.
So you actually bring up a really good point because steroid medications, even the inhaler steroid, can sometimes increase eye pressure.
Really?
So whenever I see a new glaucoma patient or somebody with elevated eye pressure, I go through a pretty extensive questioning of, do you use a steroid cream? Do you take a steroid inhaler? Sometimes people don't even realize that they're taking something that could be elevating their eye pressure and causing or making glaucoma worse.
Wow.
So very good point. But the new technology that has been really exciting for the treatment of glaucoma is minimally invasive glaucoma surgery.
Okay.
So as I mentioned to you, we usually start with eye drops, we add more and more drops, and then if we still can't keep the pressure down, then we do surgery. And in the past, the mainstay surgery for glaucoma was a very invasive surgery where we actually put a drain in the eyeball. It's an actual hole called a trabeculectomy that releases, it releases fluid slowly from the eyeball over time. But that surgery, unfortunately, has a host of potential complications, as you can imagine. Eye redness or leakage from that hole or the pressure going too low. So it was really necessary to come up with a new innovative way to treat glaucoma, to minimize the use of eye drops and to avoid doing that really big aggressive surgery. And that's where Miggs comes in, minimally invasive glaucoma surgery. So that surgery can be done at the time of cataract surgery, or it can even done in certain situations as a standalone procedure. Basically what we do is put a very, very tiny stent.
Look at this.
This is actually the smallest device that can be implanted in the human body at this time.
Wow.
It is very, very tiny, and it goes in that channel that's in the front part of the eye that I mentioned earlier that controls the circulation of fluid, and it improves the circulation of fluid inside the eyeball, and it reduces the intraocular pressure.
Yeah, that's amazing. It almost looks like a teeny little sliver or something.
Exactly.
You got. It's incredible.
Exactly. So it's indicated for mild to moderate forms of glaucoma. And for patients who are already on drops for glaucoma. And there is a very high success rate in which we can get rid of the eye drop that the patient has to take. Sometimes we get rid of one of their glaucoma drops or even two of their glaucoma drops by placing this stent in the eye. Doing or implanting that stent takes approximately an additional 2 to 3 minutes to the cataract surgery. So after I've removed the cataract and I've implanted the new lens implant in, I place the stent right in that angle in the front part of the eye.
So this is often done in conjunction.
Correct.
With obviously you're going through extensive eye exam if you're going to have cataract surgery. So this is something that you can look, and if you see a potential problem, this can be put in at the same time.
Correct. So for the patients, it's really a win-win situation. They're already having cataract surgery, so this will only be an additional step that will keep the pressure down. And I actually implant that stent through the same incision that I make for the cataract surgery. When I do cataract surgery, we make a very small incision. It's less than 3 millimeters wide in the cornea and the front part of the eye. and that stent is placed right through that tiny incision. And we've been doing this for several years now, and based on our experience and based on national and international data, the rate of complications after putting the stent in are basically the same as the rate of complications after doing a routine cataract surgery, which is very low.
Now, once the stent is in, is it something that stays in, or obviously you must do follow-ups? I mean, is there a point in time that the glaucoma the pressure can still go up, or is this maybe a solution if you catch it in time for maybe for the rest of your life?
It could be a lifelong solution, but whenever somebody has a chronic condition like glaucoma, they need to maintain routine follow-up. So I have some patients, for instance, who've had mild glaucoma, and I put in a stent 3-4 years ago. And in the beginning, I was seeing them more frequently, and now we see each other every 6 to 12 months, just for a quick pressure check, just to make sure all looks good, repeat their visual field testing, which is the test that checks the peripheral vision, make sure everything is stable, make sure their pressure is staying down, and make sure that their optic nerve thickness is continuing to be stable. And if the pressure does go up in the future, then we would go back to doing either eye drops or doing an additional minimally invasive glaucoma surgery to lower the intraocular pressure. One thing to keep in mind is, unfortunately, we know glaucoma does not have a cure. It is a chronic condition. It tends to be progressive. It tends to be more severe with aging. So patients with glaucoma, even if they've had the stent or any other treatment, they do need to maintain follow-up.
Is there anything anyone can do to prevent it? In other words, if it's within your family history, does it mean that you have a greater chance of getting it, or maybe not? Is it
so family history definitely plays a big part. So if somebody knows that they have a family history, it is very important to go in for routine eye exams in order to screen for glaucoma. If somebody does not have a history of glaucoma, there isn't really that much that can be done to prevent the possibility of it. There are some lifestyle changes that are thought that maybe could help, but nothing has really been proven. But in general, just keeping a healthy diet, seeing an ophthalmologist or an optometrist routinely just to check the visual fields, look at the optic nerve, check the eye pressure. Those are all essential.
All right, very good. And it's always good to have you here.
Thank you. My pleasure.
It's
always
wonderful.
Great chatting with you.
Great information.
Thank you.
It really is. It's absolutely remarkable, the technology.
I think that's really the exciting thing about our field and ophthalmology. There's always something new.
And the penny's being shown because it just shows
it shows you the stent, how tiny it is all the way over there compared to the penny.
All right.
Thank
Doctor,
you,
always good.
Thank you. Good to see you.
We'll be right back. So I take Flonase. I usually like twice